So, now that we've discussed the various muscles and nerves that control ocular movement, let's discuss what one might expect to see with specific damage to cranial nerves 3, 4, or 6. Let's start with cranial nerve 3. As we've discussed, there are two major functions of cranial nerve 3, controlling most of the extraocular muscles as well as parasympathetic output. Now, if you were to cut the nerve transversely, as pictured here, the parasympathetic output fibers compose the outer rim, while the output fibers to the ocular muscles are embedded within that. Thus, the parasympathetic fibers are most affected by compression. Clinically, you would see a blown pupil that won't constrict to light. Now, things that cause this type of compression include berry aneurysms as well as increased intracranial pressure. The extraocular muscle output is most affected by metabolic and ischemic causes like diabetes and hypertension. This is because the decreased diffusion of nutrients to the interior happens when there's less nutrients available in the blood. Basically, you can think of it this way. All of the nutrients are readily available to the inner fibers when things are going well. But if the blood supply is cut short, then by the time the nutrients get to the inner fibers, there really aren't many nutrients left. You can think of it as the last people that arrive at a lunch talk, all the food is already gone. So what would a defect in the motor component of cranial nerve 3 produce? This would give you a down and out eye because of unopposed actions of the superior oblique as well as the lateral rectus muscles. Also, there would be ptosis due to lack of innervation of which muscle? The levator palpebrae muscle. Now, we discussed that cranial nerve 4 controls the superior oblique muscle. Keeping that in mind, what would cranial nerve 4 palsy produce? Well, since this nerve innervates the superior oblique muscle, which helps the eye look downward in the adducted position, the eye will be elevated and diplopia will result. Diplopia in a manner that the visual fields are displaced both vertical and are also tilted. Now, as a compensation for this, the head will be tilted toward the lesion and the chin will be tucked in. This action brings down the affected eye to produce a level field of vision. This is often a good clue that you will see on a step 1 question. Lastly, let's discuss cranial nerve 6, the abducens nerve. What would a cranial nerve 6 palsy produce? Now, once again, you have to first remember what muscle this nerve controls. In the case of cranial nerve 6, it is the lateral rectus muscle. No lateral rectus means that the eye will deviate medially, causing a horizontal diplopia. These functions are important to remember not only for this test, but also for your third year, when you will be expected to pick up on these deficits on a physical exam. Alright, it is time for another flash quiz. A colleague is telling you about one of his patients who came in with an eye that looks down and out. Without further information, what is the most likely cranial nerve deficit? This is likely to be a cranial nerve 3 deficit. As we've discussed, down and out is a phrase commonly used to describe the phenotype of the affected eye in a cranial nerve 3 lesion. For visual field defects, there are really 3 rules that you need to remember, and then you can reason your way through most of the lesions. The fibers from the nasal retina will cross at the optic chiasm, and this translates into the temporal part of the visual field. You can see that, right? Temporal part of the visual field, that information goes to the medial part of the retina. Hemianopias must occur before what part of the brain? The lateral geniculate nucleus. After the LGN, individual lesions produce quadrantic anopias. Thirdly, the superior radiation carries information from the lower visual field, while the inferior radiation carries info from the superior visual field. Now, what would a lesion in the optic nerve produce? The optic nerve is before the optic chiasm. And because there's no segregation of information before the chiasm, it would produce a complete anopia on the affected side. So what would a lesion in Meyer's loop cause? Now this question requires a little bit of thinking. First, is the temporal or nasal side affected? And second, is it the superior or inferior field of vision? Now if you have a lesion in the right Meyer's loop, then you would have impairment of the nasal field of vision of the right eye, right? The nasal side. The temporal side of the left eye would also be affected, and that would also affect the superior field of vision. And so finally, when you look at the actual visual field defect, it would look something like this. The medial longitudinal fasciculus is a myelinated tract that allows for horizontal conjugate eye movements. The tract bridges communication between the abducens nucleus and the contralateral ocular motor nucleus. Thus, when the eye looks left or right, one eye abducts while the other eye adducts from smooth action of the lateral rectus and the medial rectus muscles. However, when the MLF is injured, there is a medial rectus palsy when attempting to look laterally. So here you see that the left eye does not look to the left along with the right eye. However, when the MLF is injured, there's a medial rectus palsy when attempting to look laterally. In this example, you can see that the right eye is able to look to the right and the left eye is not. The eye can't tolerate seeing double, so nystagmus will form in the eye that is looking outwards. The MLF runs down the medial pons, thus a stroke in that area in older patients can cause internuclear ophthalmoplegia. So when will you often see this syndrome come up? MLF syndrome will usually be tested as a part of the constellations of symptoms for multiple sclerosis. Bilateral MLF is pathognomonic for multiple sclerosis, especially when seen in young female patients. Don't worry, we will talk much more about multiple sclerosis in the pathology lectures. Okay, so now let's try a few practice questions. Okay, now let's do a few board-style test questions. Let's start with this one. A 59-year-old woman comes to your office with blurry vision. The physical exam reveals that her right eye is looking downward and to her right. You also notice that her eyelid is drooping. Which of the following is likely to be in her clinical history? So here, the answer is D, right? This question requires a few steps to get to the right answer. So the first step is to be able to identify that the patient has a cranial nerve 3 palsy. And that you should be able to figure out based on the description of her physical exam. The eye is looking down and out, as well as ptosis. These should all point you towards cranial nerve 3 being defective. Now, the next thing that you should have been aware of is the way that blood supply to cranial nerve 3 affects the parasympathetic and motor components differently. So you should remember this diagram. This patient's symptoms all point to a deficit in the motor component. You should have remembered that the parasympathetic fibers are more affected by trauma, compression, and increased intracranial pressure. These are all represented by choices A through C. However, the motor component is most affected by metabolic and ischemic conditions. Thus, diabetes would preferentially affect the motor component and not the parasympathetic component. Okay, let's try another question. A patient comes into your office because she has noticed that her eyelid has begun to droop slightly on the right side. Upon further observation, you also realize that her right pupil is smaller than her left one. Which of the following are you most likely to find after further testing? Okay, so the correct answer for this question is B, a bronchogenic carcinoma. You should have recognized that this patient has Horner's syndrome. Remember that this is characterized by ptosis, which is this here, as well as meiosis. This is characterized by ptosis as well as meiosis. Usually, patients will also have anhidrosis, which is a lack of sweating, but this turns out usually to not be clinically as apparent. Horner syndrome results from a lack of sympathetic outflow to the face and can be caused by numerous things. Elevated blood glucose is not thought to lead to Horner syndrome, although, as discussed in the previous question, over time diabetes can lead to problems with cranial nerve 3 as well as other optical problems such as diabetic neuropathy. An elevated optic pressure would usually indicate glaucoma. This patient would have presented with extreme pain if this was the case. Lastly, the eye looking down and out would indicate a problem with cranial nerve 3. This patient has ptosis, which can also occur due to a lesion in cranial nerve 3. However, the ptosis is accompanied by meiosis. In a cranial nerve 3 deficit, if there's a change in pupil size, one should expect to see a blown pupil on the other side of the ptosis instead of a smaller one. To answer this question correctly, you had to remember that a Pancoast tumor, which is a bronchogenic carcinoma usually affecting the apex of the lung, is one of the causes of Horner syndrome. This is because a tumor in that position will affect the second order neuron, which is the neuron that travels to the superior cervical ganglion here.